distinct pleasure and honor to introduce my great friend, Varun Kshettry, who I think in this group really needs no introduction. I think he's probably operated with many of you on this call in the Head and Neck Institute. Dr. Kshettry is assistant professor of neurosurgery here at the Case Lerner School of Medicine. He has a very unique practice. He does obviously a lot of anterior and lateral skull-based surgery with us and pituitary surgery, but he also does cerebrovascular surgery and is the director of the CCF trigeminal neuralgia program. I think that means congratulations are in order. In our world, maybe less so, V. He's also assistant program director for the neurosurgery residency program recently. He obtained his BA in philosophy of all things at the University of Pennsylvania, then did his med school at Northwestern, and did his residency actually here at CCF, which is when I met him, when he was a senior resident. During his time here, he did a infolded fellowship in microsurgical and endoscopic anatomy at Ohio State, and then did a formal clinical fellowship at Jefferson, which is a very renowned skull-based program. We were so fortunate to recruit him back. We recognized even during residency that he was a special person, a special talent, and just a special guy. And we really wanted to have him join our team as we were growing it. So I think Varun coming back was one of those pivotal moments in the maturation of our program looking back. So we're very pleased that we were able to bring him on as a partner. Since he's been here, he's done amazing things. Just to highlight a few, he set up our endoscopic and microscopic skull-based lab in the TT building, and he really has been able to spearhead our research efforts. We've had multiple multi-institutional clinical trials that we've done over the past several years, and I largely credit Varun and his initiative for making those happen. One of the accolades that he holds that is not on this slide, or maybe not even in his CV, is he's also the social chair of our group. So whether we're in Barcelona or Phoenix to come or anywhere else, we turn to Varun in hours of pinch to find the right place to go and the right restaurant to eat at. So it's not to be poo-pooed. So with that, Varun, I think this topic is amazing. I'm really looking forward to your discussion on the evolution of modern skull-based surgery. Thank you so much for taking the time.
I appreciate it, Raj, and thank you, Jamie, and everyone else in the department. This has really been one of the most enjoyable aspects of this position here at Cleveland Clinic, is being able to work with you guys and everyone in your department. You guys really have an amazing department. So here I'm going to talk a little bit about the evolution of modern skull-based surgery. I have one disclosure that I don't think is relevant for this talk. So I put together this timeline, and this will kind of serve as an architecture as we kind of go through the last century of skull-based surgery. And I'll break it up into a few, really what I would think of revolutions in skull-based surgery. We'll start off with a little bit of a historical background in the 1900 to 1940 time period, really kind of what I would call a proof of concept time period. The advent of the intraoperative microscope in the 1960s really opened up the door for what then I would consider or call the open skull-based surgery or microsurgery revolution. And that was kind of spearheaded, being able to see all of the anatomy of the cisterns, cranial nerves, and vasculature. But really the mantra of remove bone, don't manipulate the brain, and the development of many different open skull-based techniques in order to achieve better neurological outcomes. And the other aspect that came during this time period with some of the people pictured here, really kind of leaving no stone unturned, in the sense of really nothing after this time period became unresectable. There was a way to achieve surgery for almost every skull-based tumor. Very hand in hand with this microsurgery revolution is what I would consider the neuroanatomy revolution. And that was spearheaded really by this gentleman, Al Roten. He was a neurosurgeon at Gainesville, Florida. And over 30 years, he had a very successful, vibrant anatomy lab, really detailing every single little aspect of cranial anatomy from the nerves, veins, vasculature, the bone, everything. And even there's actually a very nice set of dissections on head and neck anatomy for any trainees. If you Google the Roton Collection, Rhoton, since he passed away, there's been a big initiative to basically put all his dissections online in an easily searchable way. You can even look up head and neck neuroanatomy videos on YouTube that he gave as well. And really, out of this revolution came the idea that the concept of from the lab to the OR, which is basically we need to practice and refine all our skills and knowledge of the microsurgical anatomy and take that to the OR. And really this kind of philosophy carried on into the endoscopic revolution as well, where a lot of those approaches were first developed in the lab and taken to the OR. Shortly thereafter, radiosurgery I would consider a revolution, really from the standpoint of maximizing functional outcomes and really kind of putting surgeons on notice to say, well, some of these older series are great. You got a lot of great, gross total resections, but there's too many cranial nerve palsies or too many neurologic issues, and we should be doing better for patients. And radiosurgery really gave the ultimate card in the back pocket for neurosurgeons for many of these cases where we don't necessarily have to go for gross total resection when we have a good backup plan. And in some other cases, which I'll highlight, like vestibular schwannomas, paragangliomas, actually gave us a first-line option. Then in 2000 onward, really starting around 2005, I would say, was the endoscopic endonasal skull base revolution, really for the midline skull base, all centered along the sphenoid. And the endoscopic approach really opened up the door to see the anatomy in the area in ways we could not see before, and also provide a direct route rather than manipulating brain and nerves. And for the midline corridor, really one of the philosophies that came out of this was don't cross nerves to get to your tumor. So if the tumor is in the middle, don't come from the outside in our lateral skull base approaches, cross nerves to get there, just take a midline corridor. The transorbital skull base surgery, I would not really consider that a revolution in the same way as these others, but it's important enough that I highlighted here. And I really would consider that as like just another extension of the endoscopic skull base revolution. And then lastly, we'll touch upon the molecular revolution of personalized medicine. And really trying to understand these tumors before we try and tackle them. And I'll talk a lot about that. So let's talk about a little bit of historical, the kind of proof of concept. So one of the themes in accessing the depths of the central skull base, you have a tumor here basically coming from the clivus. Historically, the challenge for something like this is how do we actually get enough illumination to see down there? How can we get enough visualization to see the details? How can we reduce the collateral damage on our way down to that area? And how can we reconstruct the area to avoid CSF leak? And we'll see these themes run as we go along different aspects of history. So just as an example, initial pituitary surgery, Fettercross in 1905. This was kind of a typical frontal, like forehead flap elevation of the frontal lobe to get down to the pituitary area. Charles Fraser at Pennsylvania Hospital, associated with UPenn, he was kind of credited with having the first idea, a true kind of skull base idea, which was in addition to doing that frontal craniotomy, why don't we remove part of the skull base, in this case, the orbital rim, in order to minimize how much we manipulate the brain. Then a couple of folks in Vienna started to have the idea, well, can we actually go through the nostrils for pituitary surgery? And these guys performed the first pituitary surgeries transnasally, and they utilized a big kind of lateral rhinotomy, superior, frontonasal incision. And then Harvey Cushing, who's really kind of considered the grandfather of neurosurgery, practiced 1900 to 1930 timeframe. He performed his first pituitary tumor transnasally in 1909, and he eventually developed a nasal speculum to be able to kind of retract tissues. But as you can see from this illustration, the nasal corridor, it's a long kind of dark, deep hole, and getting enough light and proper visualization was the real challenge, and why transnasal pituitary surgery really didn't take off despite these initial people who were trying to push it forward. These two gentlemen I'll briefly mention, they kind of prevented transnasal pituitary surgery from dying out from 1920 to 1960. They were kind of the only ones who were still advocating for it. One of the innovations Norman Dott added was adding lights built into the nasal speculum, and Guillot added the use of fluoroscopy for localization. But it wasn't until the intraoperative microscope really came about in the early 1960s that allowed kind of a reinvigoration and renovation or rejuvenation of transnasal pituitary surgery, and that was carried out by this gentleman, Jules Hardy, at Montreal. What about endoscopy? So kind of the original concepts behind endoscopy date back to Philip Bozzini in early 1800s in Germany. And he had this device, which is pictured in the top right, called the Licklighter. And it was basically a rudimentary endoscope that was kind of powered by a series of mirrors and an external candle. And he had this concept that, well, maybe we can use this, we can utilize natural orifices or openings in body cavities to be able to look into them with this kind of a device. But it really wasn't until the 1960s with Harold Hopkins and Carl Storrs where endoscopy started to take off in various fields with the fiber optic light bundle. That being said, in skull-based surgery, really it wasn't until closer to 2000 that people started to apply this technology for transnasal skull-based surgery. So next we'll go into the microsurgical revolution, and kind of the mantra, as I mentioned, that came out of there was remove bone, not the brain. And really this was all powered by the intraoperative microscope. This provided unsurpassed illumination and visualization, and really unlocked a surgeon's ability to see in a deep, dark corridor and see all the anatomy that previously was not visualized. And that allowed us in some of these places around the skull base to see, the cranial nerves and vasculature and deep structures in ways that previously we were not able to. This is Gazi Asırgil, a neurosurgeon from Turkey. And in the 70s, he was credited really with developing cisternal anatomy and cisternal corridors to get to the skull base. So using the subarachnoid spaces as roadmaps to get to areas of the central skull base. And the two main ones that he really talked about and helped develop were have now become really the workhorses of skull-based surgery, and that's the transylvian or frontotemporal corridor, which gives us access to the carotid and optic nerves in the anterior skull base. And that was used for pituitary, paracellular pathologies, aneurysms. And then he helped develop kind of the cisternal roadmap for the CP angle, which, again, today is a workhorse approach for retrosigmoid craniotomies. At the same time, and we'll talk a little bit about the symbiotic relationship with the anatomy lab, During this time period, several figures, including Osama al-Mefdi, Lollygum Shaker, and others, really had the concept, let's try and remove more bone and avoid manipulating the brain. And out of that developed all of these approaches during this time period, from transbasal to access the anterior skull base, orbitozygomatic for the paracellular area, and the anterior petrosectomy, posterior petrosal approaches for accessing the petroclival region, and the far lateral transcondylar approach for accessing the foramen magnum, all basically for ventral pathology in the attempt to minimize how much we manipulate the brain. And during this time in the lab a lot, and also with surgical experience, people began to understand, when do you pick which approach, and what does each approach allow you to access? And we kind of developed certain maps of what each approach would give us. And the idea that came out of this was we should be a 360-degree skull base surgeon. What do I mean by that? Well, if you think about a lesion like this centered around the sella, this is a craniopharyngioma, we should be able to look at any lesion and have the capability and expertise to come from any angle and evaluate the pros and cons of each of those to see what would give us the best tumor exposure and resection with the least morbidity. And going along with this was really the study of, what does each surgical approach give you in terms of exposure and surgical working space? And that's also where the neuroanatomy revolution came in hand with this microneurosurgery revolution. And some key aspects to this was really exploring what I would call unseen anatomy, meaning, of course, this is anatomy that, even Vesalius and others, published and talked about in the 1500s, but really to the detail and degree that's relevant in a microsurgical way was really studying anatomical variations, helping surgeons to develop X-ray-like 3D anatomical understanding. So if you expose structure A, you know exactly where to get B, where to go to get C, etc. So kind of developing roadmaps. The development of new approaches, and also quantitative neuroanatomy, which is a little niche research field of kind of determining what each approach would give you. I give the example here of, this is more in endoscopy, but the concept of unseen anatomy. So of course, we all knew what the superior hypophyseal arteries, and textbooks would talk about how, they supply the infundibulum for pituitary function. But one of the things we did not really appreciate on a surgical level was the contribution to the optic chiasm and optic nerves. And for example, with craniopharyngiomas, which fill this space, transcranially, when you come from above, this is often the blind spot. You're kind of reaching around the optic nerves to remove the tumor. And we, in general, had a higher rate of optic vision deterioration with that approach. And really, we started to understand these superior hypophyseal arteries. Yes, they supply the stalk, but there's a very rich irrigation that they provide to the optic chiasm and proximal nerves. And preservation of these was critical and much more feasible from an endoscopic endonasal corridor, because you could see them well. And here I just kind of took a little sample video. So this is an optic chiasm. This is a craniopharyngioma cyst. And we want to sacrifice the branches that are going to the tumor, but then the branches that are sticking with the optic chiasm, we want to kind of separate them, develop the planes, and mobilize them with the nerve on either side. And so here, all these little branches we can mobilize with the optic nerves, and then just come directly now at the cyst. And all these are preserved irrigating. So we've seen much better vision outcomes with the endoscopic endonasal approach. And I kind of already highlighted Al Roten here. Quantitative neuroanatomy, as I mentioned, A lot of research in this time period came about where we would compare one approach to another, and using neuronavigation and Cartesian coordinates measurement systems, measure out exposure of the brainstem or exposure of the clivus, comparing one approach to the other, or to say, well, if we extend the approach and remove this area bone as well, what does that add to us? And really help to understand when do you use what approach and when do you need these little extensions. Next, I'll talk about a little bit about radiosurgery, which kind of, I would say the mantra here was function first. This is Lars Leksell. He was a neurosurgeon in Sweden, and he really developed the concept and initial radiosurgery machine. And he kind of said, well, think about this. This is the Leksell frame. Actually, people who do like deep brain stimulation, even to this day, they still use this to place their electrodes. So a very accurate way of stereotactically targeting a lesion. And he said, well, instead of using a needle, why can't we put narrow beams of energy to destroy tissue? And he actually developed the first gamma knife, looks like a giant football helmet. This is from 1968. Since then, of course, technology has improved, and there's many different radiosurgery units. Here at Cleveland Clinic, we now we have gamma knife since the 1980s, and actually just recently acquired our second machine. I think we're one of only 3 or 4 places in the world that has the volume to run 2 machines simultaneously. So out of this came this kind of concept, because in skull base, actually the majority of pathologies we deal with are benign. Meningiomas, schwannomas, paragangliomas, pituitary adenomas. And the concept of, well, we don't have to go for broke. We don't need to always go for a complete removal, particularly because we have a good backup option. If we leave residual tumor, in many of these cases, we can achieve reasonable results with radiosurgery. There are some pathologies, and we'll highlight a couple of things where cavernous sinus meningiomas and paragangliomas of the jugular frame, and we're really, I would say now radiosurgery is kind of a first-line option over surgery. I mentioned about kind of a backup card in the back pocket in some skull-base meningiomas and pituitary adenomas. And in some cases, for example, vestibular schwannoma, it can be either. It could be a primary upfront treatment or a salvage treatment in a facial nerve preserving surgery. So just as a couple kind of pathology examples, so cavernous sinus meningiomas we'll give as an example. Obviously, these are benign tumors, but in a difficult location with cranial nerves supplying the extraocular muscles, a carotid artery. And when we looked at early surgical series, this was from Laligam Shaker and Osama Al-Mefdi, 2 of the people that I mentioned in the microsurgical revolution. Here we look 65 patients, 18 of them he had to do an internal carotid artery bypass. CSF leak and new cranial nerve palsy rates were pretty high in Al-Mefdi's series. Actually, this was, in my opinion, pretty impressive that it was only 26% new extraocular dysfunction. We can see stroke and even mortality remain pretty high in this group. And one of the things that came out, and this was a paper in '95, where they actually looked at the histology of sacrifice nerves in this, and found that actually many of them, there was tumor invasion in the nerves. And that was kind of thought to be, well, this must be a reason why our rates of cranial nerve palsy are high, and complete removal is difficult in these tumors. Radiosurgery really has demonstrated excellent outcomes in these patients. This was a systematic review, and 10-year progression-free survival, depending on the paper, 70 to 97%. So not perfect, but good. The really valuable here, you can see new cranial nerve palsy is only 1% versus 30 to 50% in surgical series. And new internal carotid artery stenosis or stroke was very rare, less than 1%. And so really, how is this practice now for isolated pure cavernous sinus meningiomas? Well, of course, many of those we can just observe, but if there's growth or deficits, SRS or radiosurgery really has become the first line option. When do we do surgery? It's really kind of a case like this, where we just want to remove the portion that's outside the cavernous, and maybe if we need to decompress the optic nerve and get to a state like this, and then leave all the tumor inside the cavernous sinus proper and observe that or do radiosurgery to that. How about vestibular schwannomas? So, vestibular schwannomas, it's a challenging patient counseling pathology, in my opinion. It's very unlike a pituitary adenoma, where most of the patients, what I'm trying to achieve, it's a restorative surgery. So I can see them and tell them, I'm going to make you better, whether that be your vision, getting rid of your Cushing's or acromegaly. Vestibular schwannomas, really the restorative aspect is in big tumors like this, which is really the minority of tumors we see in the US at least. And often tumors we see, it's something like this or this. And these patients, they don't have trigeminal hypoesthesia or brainstem compression, but they come in, the three most common symptoms are headaches, and I see them in clinic and I say, well, sorry, maybe not related or not going to help your headaches. If they have tinnitus, we say, sorry, actually, observation, surgery, or gamma knife, nothing's really been shown to be a better management or to improve the tinnitus. And then hearing loss, we have to tell them, actually, sorry, the hearing that you've already lost, I can't bring that back. And in fact, most of our treatments in the long run don't do a great option in hearing preservation. So for patients who come in, and this is the most common, that they have only, maybe these symptoms, really our philosophy here is kind of to maintain, or it's more of a maintenance therapeutic approach here to prevent tumor growth and not make them worse. Of course, there's some patients with disabling mild, moderate to severe vestibular symptoms we can improve with surgery, but it's really only these latter people, with big tumors that we can restore or make even much better. So with that in mind, the management of small acoustic tumors that are growing, that's where the debate's really been about whether we should be doing surgery or radiosurgery. And there's been numerous papers. This was kind of one of the papers that came out of Mayo, looking at quality of life, comparing in a prospective fashion, comparing microsurgery and SRS only in the small tumor category. So here, the mean tumor size was only 12 to 14 millimeters. And when you look at, this was before the PanQual and which is one of the more commonly used quality of life surveys now, but basically a modified SF-36. That was overall unchanged in the SRS group at 3 months and a year, whereas in the microsurgery group, there was kind of long-lasting decreases at 3 months and 1 year. And final facial nerve outcome, was overall much better in the SRS group. And so when we look nationally, overall, I would say that in the last 20 years, a lot of these smaller tumors have gone towards SRS. I think in our own practice, probably about a third of tumors, we go to primary radiosurgery, whereas still 2/3, we would go to surgical resection, but everything, is a case-by-case basis. But the other aspect to the equation was radiosurgery really put surgeons on notice from the standpoint of facial nerve outcomes. So even in the largest series, people publish, well, here's my series of 1,000 schwannomas I've done, you know, in the 80s, 90s, 2000s, and here, you know, kind of bragging about how great my outcomes are, where good facial nerve outcome was in 70 or 80%. Really, radiosurgery kind of reset the standard to say, yeah, that's not good enough. You know, we really should be striving for, you know, greater than 90% even in surgical series. And so often we do something where, especially in big tumors like this, where the facial nerve is extremely stretched out, and sometimes even it's so thin you can almost see through it. This is a kind of a case example where we would do, you know, an aggressive subtotal resection and then observe the remainder. And if it grows, we could then deliver radiosurgery to the residual component. And so this is a patient kind of where in a normal circumstance, a really good facial nerve outcome, if I was obligated to get gross total resection here, maybe in the kind of, you know, 50, 60% range, and now we can get these patients greater than 90% a good facial nerve outcome. I'll just briefly mention glomus jugulare tumors. You know, that's another pathology where I'm going to skip over some of this. In surgical series, the rate of new lower cranial nerve palsy was quite high, and SRS has shown, again, not to be perfect, but can be some advantage to lower morbidity and still achieve reasonable tumor controls. This data of 10-year progression-free survival, 70%, came out of paper from Cleveland Clinic of a 20-year experience from that. So we'll go transition into endoscopic endonasal surgery. And what are the really the advantages that came out of this revolution? Well, we can get illumination closer to the target, give us a wider field of view. We can look around with angle lenses. We can take a direct route and avoid manipulating brain. And for midline pathology, we can go straight at it and avoid crossing nerves to get to the pathology. The main disadvantage was really in the beginning, people said, well, we can't do safe fine dissection endoscopically because it's 2D. But, you know, I guess over time, kind of that's been debunked, and I think largely been driven by a younger population of surgeons who really grew up in the video game generation and were used to playing in 3D space on Atari and Sega, and, you know, 2D endoscopy was really not a big deal. So if you think about looking at the pituitary gland, this is kind of the view you might consider in the old days with just naked eyes and headlight. So it's kind of a dark, limited view. Then the intraoperative microscope came, which gave great detail and illumination. The problem still was the field of view, because it's a long, narrow, small corridor, and even though we kind of jam a speculum in those cases, your light source and microscope are way out, on average about 60 centimeters away. And then came endoscopy, where you actually take your eyes, go into the sphenoid sinus, and then look around, and really gave a unparalleled panoramic visualization of the anatomy. Of course, as you guys know, there's angled things that allowed us to expand the working corridor, look up and down, and many devices that have gone along with that. Development of neuroendoscopic suites. This is ours, or 12 here. The ability to work 2 surgeons with 3 or 4 hands. And really, while transnasal surgery for the first, you know, century essentially was all limited to the sella, as we got this unprecedented visualization, people began to say, well, why can't we open up the planum and look at pathology here, or open up the cribriform and come up this way, or go straight to the clivus and come that way? And that led to the development of all these different sagittal plane approaches. And so here I just put some kind of pathology examples that now we can we tackle often endoscopically. So craniopharyngiomas, really the most direct and best visualization. This was a systematic review. Really, this was published up until 2010, which is kind of really just the early endoscopic literature or experience. But just to summarize, higher gross total resection, lower seizure rates. CSF leak was quite high, 18%, but that's gone way down in the subsequent eras, refining our reconstruction. Vision improvement was much higher, and new vision deterioration was much lower in the endoscopic group. I'm going to skip over a couple of these things here. This is just a case example, just to highlight some of the anatomy that we can see. This was a craniopharyngioma. So we open up the sella down here and then the tuberculum above that. So we're in the arachnoid spaces, and here, same thing, we're going to isolate out the branches that are going to the optic chiasm, which is up here, sacrifice branches that are going towards the tumor, and develop our corridor and plane. These are scissors that are actually on a single shaft, so it's like tubular shafted instruments that we use. This is now central debulking, typical craniopharyngioma material. This is the easy part, is the central debulking, and then the hard part is coming out extracapsular, where we need to carefully tease this off from all the perforating vessels. This is coming from the PCOM here, separated from the hypothalamus, and here this is coming from the basilar apex and separating it from the left P1 or posterior cerebral artery. And this was kind of in the early stages. People said, well, you can't do this in 2D, you need 3D. And people tried 3D endoscopes and things like that, which ended up adding a little bit of bulk and really not adding much benefit. This is the mammillary bodies in the back. And then really one of the biggest things was our ability to look up and see the hypothalamus, because that's really a blind spot in transcranial surgery, is you don't get a great view of the hypothalamus. And so hypothalamic injury became much less with the endoscopic endonasal approach. And so here we're dissecting it off the hypothalamus under direct visualization and opening up into the third ventricle already. We see the thin membrane that covers the third ventricle floor. And then really a difficult tumor like this, we have achieved a good removal, complete removal. And this is a 13 millimeter cottonoid. So really our opening is about 10 millimeters to access this whole thing. So what else can we tackle? We can open up the planum sphenoidale and remove meningiomas. We can open up the cribriform and tackle olfactory groove tumors or nasal cancers. Esthesioneuroblastoma is a common one. We can go directly back to the clivus and have a very direct route for chordomas, chondrosarcomas arising from the clivus. And we can even, we don't do a lot of these, but even go down to the C1-2. And for C2 pathology from structural instability or tumors around C2, we can actually do an odontoidectomy to address ventral pathology at C1-2. What was the alternative? So open approaches to the clivus. During the open microsurgery revolution, that was, basically the transbasal approach was the most common. So a frontal craniotomy, cranialization of the frontal sinuses, and then basically coming through the skull base and doing ethmoidectomy to take that nasal corridor all the way down to the clivus. And people said, this is the kind of angles you can achieve. The other common approach was maxillotomy approaches to get to the clivus. And here also a systematic review. This is from 2011, looking at early experience of endoscopy, and I think the outcomes have improved even since then. Gross total resection was higher, complications lower, meningitis lower, but this is kind of the most important thing, was look at mortality in the open approaches series was 21%, so very high. here in the early endoscopy was 4 or 5%. I think even today that would seem excessively high, and it's probably 1% or less here. So let's take a pituitary tumor, for example. So this kind of a tumor, if we just did a standard transcellular opening, and we said, what's the highest we can see or reach? Really, it would only be this. And trying to access this kind of tumor would be difficult. That's the main advantage of endoscopy, the ability to open up bone here and look higher and look up with angled scopes. For example, if you went to our neighbors with this tumor, you would get a craniotomy to remove this top part, and then a transsphenoidal microscopic approach to remove the bottom part. Whereas now we can do this fully endoscopically using expanded approach to get higher and use angle cameras to look up. So this is just, here we've done the approach to remove the tuberculum and planum. This is the sella. We first just open the sella to say, hey, let's see what we can remove first, but obviously we couldn't get to the top of the tumor. Let's see if that plays. And so then we say, okay, we will open up the dura of the tuberculum and planum. And here we're looking within 30-degree scope. And now that's allowed us to reach over the top of the tumor and start to deliver it down from the anterior cerebral arteries. We'll open it up and do some central coring out to soften it, and then finish delivering the tumor down. So being able to tackle tumors like this fully endoscopically and still achieve a complete resection. With the endoscopic revolution, there was a development of coronal plane approaches going out to the side, and we said, well, we can actually work in the cavernous sinus, we can access the inferior and medial petrous apex, we can get to Meckel's cave, we can work on the orbits, and lower down we can work towards the jugular foramen. Reconstruction, the early major criticism of this expanded approaches, really in 2006, Haddad and Bestig, I'm going to pronounce that incorrectly, but what we call the HB flap, which is really a pedicled vascularized nasoseptal flap that's become the workhorse for reconning expanded endonasal approaches. And most centers, including ours, has kind of developed algorithms, and for a simple defect like this is removing a pituitary, and here there's really not much leak or minimal leak, but there's a bulging diaphragma. Many of these we can just use a synthetic graft only with some glue, and that will remucosalize and heal well. The main thing we often use in these expanded approaches, where we open up into cisterns and ventricles, is this bilayered fascia lata. So we take 2 layers of fascia lata, suture them together in a button, and we make this 4 sutures kind of to approximate the size of the defect. And so one layer goes in the dura, the other layer goes on the outside, and then after we've placed it with the sutures all in the corners, we put the nasoseptal flap bolstered with glue and absorbable materials. And then when we really work on some septal nasal cancers and there's no good septal tissue that's non-diseased, we call our excellent recon team. This is a flap Mike Fritz did for us, really creating a very skinny fascia lata pedicled flap that can really be a highly malleable, highly contourable flap for the skull base. And this is him, delivering it into the nostrils in a minimal access with a little opening here to tie it into a facial artery, and we can put that and cover the entire skull base. This actually covered everything from like essentially cribiform to foramen magnum on the clivus. As I mentioned, I'm not really going to talk about the transorbital in the interest of time, but I consider it an important extension of endoscopic endonasal. And then the last thing I'm going to highlight is what I would call the molecular revolution. And, coming back to our timeline, it's interesting when I look at the North American Skull-Base Surgery Society meetings, 10 years ago, when you go to a meeting, really all the science that was being presented was, here's, the anatomy of this area, or here's my surgical outcomes, and, here's how great of a surgeon I am, and it's very kind of macho type research. But if you go to a meeting now, actually, you'll see how much is actually devoted towards understanding these tumors on a molecular level, and the insights we can develop. And really that's become the next revolution that we've entered in skull-base surgery pathology. Of course, this is not new to skull-base. This is even predating in other areas of various types of cancers. But because skull-base tumors are mostly benign, I think it took a little longer to get to those areas. And I'm going to just highlight a couple pathologies really as examples of this. So the first is craniopharyngioma. This was a Nature Genetics paper that came out in 2014 from Mass General and their group at Dana-Farber. And really they did whole exome sequencing of craniopharyngiomas. And specifically, so craniopharyngiomas come in two subtypes, adamantomomatous and papillary. And the real finding was in relation that almost all of these papillary had a BRAF mutation. And not only did they have a BRAF mutation, but this is in the setting of a pretty bland genetic background. So craniopharyngiomas, when you look at the somatic mutation frequency, it's pretty low compared to, for example, melanomas, where there's a much higher rate and a much more complex genetic mutation background. And that opened the door to, well, we have a targeted inhibitor that we use for BRAF and that's been used in melanoma in combination with MEK inhibitors. Can we use that in papillary craniopharyngiomas? And this was kind of an initial case report in 2015. This was a patient who had 4 surgeries in 1 year for rapidly recurring recurrences, and they put him on a BRAF MEK inhibitor combo, and you could see from day 17 to 34 quite a dramatic response, both in the solid and cystic portions of the tumor. And this kind of, they actually did consolidation surgery after this and found increased macrophage infiltration into the tumor, increased CD8 T-cell infiltration, showing really that this opened the door for an immune response to the tumor. And so this obviously raised questions. What's the durability? How quickly will tumors develop resistance? When do we use it? Do we use it as a salvage? Should we consider neoadjuvant treatment? There's an ongoing trial trying to enroll 36 patients using this BRAF inhibitor. The main issue is really the rarity of this tumor. So it was a great discovery in a tumor that really no one has. So, we looked at the kind of most comprehensive epidemiology of craniopharyngiomas. And here you see it's about 1 in a million people have this tumor. And even with that, 80% of those are adamantomomatous and only 20% are papillary. And then on top of that, you throw in, it has to be, papillary tumor that, doesn't respond or do well with surgery and it recurs. So that trial has had difficulty enrolling. The last example I'll round out in the next couple of minutes is with meningiomas. So meningiomas are a very diverse group of tumors. And I'll highlight this example. This is a patient came in with a petroclival tumor. She had multiple cranial nerve palsies. Interestingly, she had a car accident, and this MRI showing a small version of this only a year ago. And so we did a retrosig. We took out the back part, and it came back grade 1, very kind of bland looking tumor, which didn't quite make sense with how much growth we saw from here to here, as an average benign tumor would only grow 1 or 2 millimeters a year. We see that hers grew just in 6 months. We did salvage radiosurgery that gave us, response for 3 years, and then it grew. And then we took her to do a combined petrosal approach with with one of the neurotologists, and got a good removal there. But this is a good case that highlights that really this is an aggressive tumor, but the pathology we got did not match the clinical course. And I'm going to skip over some of this here, but this has opened the door to really understand the genetics of these tumors. And just in the interest of time, I'm going to skip over some of this stuff. A lot of work has gone into understand the genetics of what drives these tumors. It's not just specific mutations, but the overall degree of chromosomal instability. And various groups have come up with scoring systems looking at, okay, let's compare a scoring system of genetic mutations to histology. And here we can see, in this group, a grade 1 tumor with a aggressive genetic looking background did much worse than a histology grade that was aggressive or cancerous, but a very bland genetics. So in many of these cases, the genetics can outweigh the histology. And that's expanded to epigenetics and similar classification systems. And unfortunately, I'm just going to pass over this in the interest of time. But the end result is that DNA methylation can do better than histology grading to predict behavior. So I'm going to skip over this. In conclusion, the main things that we took away from, if you take away from the evolution, is we stand on the shoulders of giants. The mantras that have come out is remove bone, not brain. From the lab to the OR, take our work in the lab to the OR. Become a 360-degree skull-based surgeon. Function first, complete removal second as our goals. Don't cross nerves and take the path of least destruction. And with molecular insights, to destroy the enemy, you must understand it first. And lastly, I'd say that skull base is a team sport, and I've been blessed to have a wonderful team in your institute to work in the anterior skull base, our lateral skull base, and the head and neck surgery. And when we get in trouble and need to repair defects, our microvascular team as well. So I'm going to close out with that, and I'll take any questions.
Great. Thank you very much, Varun, for a really great overview. And I think that historical perspective is so important. And the only other comment I would make beyond sharing, obviously, your enthusiasm for all the endoscopic stuff is, whereas earlier there was always these technical limitations that you nicely highlighted, advances, revolutions from microscope to endoscope, and so on. I think now that we've gone deep into the endoscopic realm, what we're now doing is kind of expanding. And that's how I look at the orbital stuff. It's not a technological innovation, it's a team and teamwork innovation that allows us to do the intraconal surgery or the tone surgery that I know, you highlighted you're doing with Dane. So I would just like to thank you on behalf of the group.
Sure.
A lot of this stuff, we are kind of on the cusp of what's capable and what's not. And you don't always know where on that line you fall. And I think inherent to some of this is an uncomfortableness, an uncomfortableness being in territories that we aren't the masters of, or you may not be the masters of. And I must say, having a team as strong as ours is what lets us get through those uncomfortable moments. So thank you very much on behalf of the entire institute. I didn't see any other chat questions.
I have a point. So thank you. That was fantastic. And I lived through the very early days of endoscopic skull base surgery. In fact, I'm going to forward on to you the first reported case of a endoscopic repair of a CSF leak, which was reported from here. Frank Pepe was actually the lead author, coincidentally, back in 1989. We submitted that article in 1987, and we had terrible trouble getting it accepted because we would get reviewers back saying, this is just not conscionable to try to repair a CSF leak endoscopically. And it took us almost 2 years to get it published with the reviews and 2 different journals and you name it. So it is interesting how the people that are kind of innovative at the beginning are considered heretics by some people. So.
Yeah, that's exactly true. You know, particularly with the whole infection and nasal contamination, and you can't cross from the nose into CSF. You know, that's had to be debunked.
So I'll send you that article just for fun.
Yeah, I appreciate that. Thank you.
Hey, Varun, great lecture. In the historical timeline, how would, although you talked about endoscopy, where would you put stereotactic navigation in your continuum there to really change what you're doing?
Yeah, good question. So I would say that while we do use neuronavigation basically on every case, I would say that there's a lot of cases where we have it in the room, but we never even use it because so much of our pathologies are all anatomically based and anatomically guided. So while I would say more broadly in neurosurgery, that was a revolutionary aspect, I'm not sure that it would necessarily have that same degree that I would make it a revolution in skull-base surgery per se, but the timeline is really right around the radiosurgery, the same development of stereotactic techniques to deliver focused radiation. The same technology was being brought to the OR as well.
Thanks. I have one more question. The pathology that you showed, all of them seem to be well encapsulated. Is that the norm for this? Is that what makes it so possible to do?
Yeah, you know, I think certainly unlike treating gliomas or, you know, even metastases, the nice thing with skull-base tumors is they look so different from other structures. So, you know, really that's where our visualization is key to have good lighting and fine detail to see the difference between, you know, tumors and the adjacent brain or nerves. But typically we can all see the difference. And because these are benign pathologies, for the most part, they tend not to be as infiltrative into those neurovascular structures like we, you know, can see with cancers.
That was great. Thank you, Varun. I do have a question. Obviously, the technology is not there yet for nasal robotics assisted surgery, but are there anything in development, especially with the more Medtronic kind of technology in terms of transnasal robotics approach?
Yeah, that's a great question. Of course, you know, to be able to have that kind of multi toggle, even to suture in the nose, that's always been one of the things. Is we wish we could suture our flaps up and things like that, but it's, you know, painful and we can usually work our way around it. The main issue with robotics is just how big those ports are, as you mentioned, in the nose. And the other major limitation just on a neurosurgery level, so why don't we use robotics even in lateral skull base and other approaches, is the haptics for the level of haptics we need when having tissue manipulation of cranial nerves and cranial vascular structures. It's not there. And I'm not sure how long it's going to take to get there. But yeah, I would say that's kind of the main limitation. So the space we're working in now is really in supplemented technology with augmented reality or virtual reality, or incorporating navigation and neuromonitoring as safety mechanisms with our instruments and drills. That's kind of the more realistic and ongoing phase of technology, I would say.
Anyone
All right.
else? Questions?
Very good. Well, it was very enjoyable for me, and I appreciate the opportunity. Thank you so much.
Thank you, Varun. We had a really great turnout, so thank you so much. Amazing lecture.
All right. See ya.
Everyone.
Bye.